Hi and a very good evening all of you. So in our last clinical discussion, we said about osteomyelitis. We differentiated it with similar lesions like condensing osteitis. We differentiated it with various lesions of cementum. Okay, so we touched here and there of osteomyelitis. So in this lecture, what I'm going to give you is a much more detailed description about different types of osteomyelitis. Now, it's a very, very important topic for NEET MDS. Now, my advice to those students, those crash course students, okay, those who are writing the exam in the next 2 months, don't, if you're watching this lecture, if you have no idea about osteomyelitis, watch it quickly, okay, because there's going to be a little detailed lecture. Now, if you really want to get an idea of what is being discussed in this particular, what are the key points which will be discussed in this particular video, do one thing. Go to the last part of the lecture and see the summary. Okay, see the summary, and in the description I'll give you the where exactly the summary starts. Okay, in one of the comments, I'll pin at the comments, and where the summary starts, go there in that particular number and you can listen to the summary. In case if you have any problem with any of these key points, come back and listen to that part. Okay, so now what I'll be discussing, or how the methodology of discussion is going to be, like as usual, we'll be starting with the basic definition. Okay, and we'll be understanding the definition of the osteomyelitis. Then we will understand the causative agent. Okay, and yeah, understandably it's an infection, and different types. This is a very important part. Different types. Now, how to differentiate different types based on the clinical features as well as etiology, based on radiographic features, very important. But a few of this which we have discussed in our previous lecture, clinical discussion. Then treatment part, not very important but good to understand. And then finally a few more points to note. Okay, very key points to note for the exam perspective. Okay, and finally I'll give you a summary of this. Now, if you come to the definition of it, it's an inflammation of bone marrow and its contents. Okay, I'll tell you exactly. Let me go a little bit more. And often due to infection, understandably. And please note, it begins in the cancellous bone and spreads to the cortical bone. I'll show you cancellous and cortical bone. Okay. Now, basically, people have this confusion. What is cancellous bone? Cancellous bone is same as spongy bone, same as trabecular bone. Okay. That's basically osteology in anatomy. I'm not going into details of it. But if you just come to this particular picture out there, I'm going to explain this picture for you. If you see here, this is the bone marrow. Okay, I'll just zoom it out further for you. This is the bone marrow, and this is where the spongy bone, the center part, okay, where we have the spongy bone, and to the sides of which we have got the cortical bone. So basically it says that, this is a very important point. Okay, it starts in the bone marrow. All the infections, the osteomyelitis related infection starts in the bone marrow, that is in the trabecular bone or spongy bone or cancellous bone, and then it spreads to the sides into the cortical bone. So it's an MCQ by in itself. Okay, and basically the cause is basically infection. Okay, so that is what we're going to come next, the causative agent. Okay, now please note, it's usually a polymicrobial infection. Now when it comes to NEET MDS exam, okay, polymicrobial infection, the term called polymicrobial is very little significance. They ask you which of the following most commonly causes osteomyelitis. So that's a question. And the most common causative agent is Staph aureus, Staphylococcus aureus, plus Staph albus and Streptococci. But that's not a question. So that's the first key point which we have to note. Okay, I'll just write the key points here whenever I'm coming across it. So Staph aureus is the first key point you have to note. Okay, now even in, okay, I'll come to that. Now please note, it also caused or polymicrobial. So there is bacterioids, this porphyromonas are there, Prevotella are there. So all these species are involved. Okay, not very significant basically. But one question, in infants, what's the organism? Now people confuse. Infants, okay. It's Staph aureus. So in infants, what is the causative agent? Is the question asked. Same thing. It's the same Staph aureus. Okay. So the key point here, I want you to notice Staph aureus. Now types and etiology. Different types are there. I'm going to discuss on each type. There is acute, suppurative. So two suppurative. Two suppurative means pus. Okay. You can see the image there, the pus draining out. So that's suppurative. So two suppurative are there, acute and chronic suppurative. Then basically there are two sclerosing type, that is chronic, basically sclerosing will be chronic. Okay, and its spelling is on sclerosing. Okay, sclerosing. Okay, so focal is there, focused, and diffuse sclerosing is there. Okay, then finally there is periosteitis. Rather than sclerosing, it's periosteitis. I'll come to what exactly the differences of each type are. Now basically suppurative has to be a direct effect of infection. The body is being destroyed due to infection. Okay, now it's destruction basically. When it comes to sclerosis, it's not destruction. I'll come to that. Okay, now basically what happens is there is a periapical infection. Okay, there is caries, there is periapical infection, or it can be fracture. I've seen cases with, you see this among homeless people. Okay, I've seen people who are homeless got into accidents. Okay, and they have literally, I've seen a case where a patient had moving jaws for 1 month. 1 month. Okay, is there? He's come from some other states and he's been homeless, and he came to us with literal osteomyelitis. Osteomyelitis is very difficult to treat, and there was other patient also who was very normal. Okay, you never feel that this person has any reason for osteomyelitis, and it was very difficult. This osteomyelitis is very, very difficult to treat. Okay, now fractures, one, that is gunshot wounds, then spread from the blood, hematogenous spread can also happen. Okay, so that patient was literally mobile. We can't believe that the jaws are moving apart and the patient is having food, everything. He said he was having pain while having food. Okay, and that's why he has come. Okay, then we trace the history. He had a road traffic accident and all this. Now, what is going to be the response? Definitely, I told you it's bone destruction and pus formation. Okay, understandably, it's a suppurative infection. It's a suppurative infection. So now that's the acute suppurative. So what about chronic suppurative? Same thing, direct effect of infection only. Okay, but basically it's either, like I told you, the acute infection getting worsened into a chronic. Okay, and you'll see the more destructive process happening. More radiographically, you'll see even more destruction. Acute radiographic is very, very little. Now it can be direct spread from a dental acute infection, like I told you. Now the response is going to be the same: bone formation and pus, bone destruction and pus formation. So basically in acute, what you need to see is that basically it's destruction and pus formation. Okay, now if you come to chronic focal sclerosing osteomyelitis, my name says it's a proliferation. Okay, please note, it's a proliferation of it's a sclerotic response. Okay, it's a sclerotic response. Please note these terms here. Okay, it's a proliferation, it's not a destruction, it's a kind of an immune response. Okay, rather than destruction. Okay, so to what? To low grade infection or irritation. Low grade infection. It should not be definitely fractures. Like caries. Okay, like the caries teeth on the mandibular teeth. And it has to be that in cases where children and young adults, not like the case I told you. It has to be young children with good immunity, so that there is a proliferative response. Proliferation. Okay. Now some students told me, please include image for everything. And please understand, we are preparing for NEET MDS. Now, the tactic for NEET MDS preparation is what? Maximum amount of information in minimum amount of time. Now, what I do is, in fact, I go a little more detail. It's like, you can't say that maximum information, because I teach you a lot of basics. Okay, I go into a lot of description, but then if I include pictures also, this lecture is going to be very, very long. Okay, so please understand that whatever required, I'll be giving to you. Some students, they wanted that shortcut method in the sense, image for everything so that I can remember everything. Now see, in today's world, you have Google. If you want to know anything, there is images. But whatever is the key, if I want you to show you the bone marrow, definitely I can show you. Or radiographic appearances, I can show you. But then, everything with image. One student, not this year, 2 years back, I guess, one student told me that my professor, he teaches everything with image. Everything with image. So I asked him, who was like, basically, which subject were you learning? He said radiology. So he teaches everything. No, basically radiology has to be explained with image, but every subject can't be. Okay. Anyway, but wherever needed, definitely we'll include image and we'll describe with image. Okay. Now it's a sclerotic response, very important. Now basically the location, that's also very important. Mandibular first molar. Okay, this is a very important key point there, mandibular first molar. Again, the response is different here. It was pus formation and destruction. Here it is sclerosis. Okay, but it is localized to one particular area, unlike the next one which you are going to see, that is more spread out. Okay, so it's sclerosis basically and not destruction. Please understand, it's sclerosis and not destruction. Okay, so that is chronic focal sclerosis. Now if you come here now, okay, good to explain an image here. If you come here, see this, this is a sclerosis there, this is a sclerosis there due to periapical. It's very focal, localized, very focal, and it's due to caries in the mandibular teeth. Understandable, isn't it? If you come to the next, it's more a kind of cotton wool appearance, which is chronic diffuse sclerosing. I'll give you the details. And it's not due to caries teeth. Please understand, there's no caries here. And it's more a kind of a diffuse look. Okay, you can see there's a diffuse look. Okay, now, so that is about the chronic diffuse sclerosing. I'll come to the radiographic appearance. So diffuse sclerosing is same as focal, but what is the difference? What is the key difference? Basically, they say that it's due to, I've explained this in the previous lecture, due to extensive periodontal disease, not caries. Okay, that's one difference. Extend to a larger individuals, and very, very importantly, it's older individuals. Older individuals, where the sclerosis, now again, low grade infection has to be, it can't be fracture and all. Low grade infection like low grade periodontitis or kind of trauma, mild trauma and all in older individuals. So the sclerotic, what we saw was the focal one, okay, the focal was in young individuals, okay, and diffuse is in, this is a very important point, diffuse is in older individuals, okay, in an older individuals. Please understand that. That's a very important point. Okay. Now, other it's self-descriptive, it's sclerosis and all this. Now, a final type which many a time question has come is chronic osteomyelitis. Again, it is chronic with proliferative periosteitis. Basically, the periosteum is proliferating in simple terms. Okay. The outermost part of the bone is called periosteum. Okay. Now, if you can see, okay, this as you can call it as the periosteum, outermost part, this gets proliferated. Now in sclerotic, where did we see the problem? More inner. Okay, it's into the entire bone, it's sclerosis entirely. Okay, sclerosis in its entirety. But when it comes to this Garres osteomyelitis, it's a proliferation of, rather than sclerosis, it's proliferation of new bone formation in the periosteum. Okay, so that is chronic osteomyelitis with proliferative periosteitis. Now, few points to note here. Etiology is same as sclerosing type. It can be the mild carious lesions. Please note. Then, but the response is not sclerosis. What is the response? What did I tell you now? It's a periosteal new bone formation. Okay, please understand. Sclerosing and periosteal new bone formation. Now, yes, but in sclerotic type, what do you see? It's an involvement of entire bone, not just periosteal. Its entire bone is involved, and that is not just periosteum. That's a key difference. Okay, so Garres, I'll just give you, okay, 1 internet, I'll give you a very important information here that in Garres, okay, in Garres, the key word here is going to be periosteum, okay, periosteum. So hope you understood the different types, okay. The first type is basically infections and direct infections, okay. I've not given the description out there, but yes, then you have proliferative, where you have focal and diffuse focus in young individuals, diffuse in older individuals, and all those key areas. Okay, I'll give you a summary in the end. Now, yes, coming back, where is the location of Garres osteomyelitis? It's very, very, very important key question. Okay, it's a very important key question there. It's tibia. Your Schaefers say it's not your jaw. If you see other types, yes, especially focal sclerosing. Now, one more thing. Focal sclerosing osteomyelitis, other name is condensing osteitis. I've already said this, okay, in the previous lecture. So here it is tibia. Okay, very important question. Okay, and in case of jawbone, it is exclusively in mandible. Basically, please understand, most of the osteomyelitis is seen in, or if not all the osteomyelitis are seen in mandible only. What is the reason? The problem why osteomyelitis is happening is that there is compromised blood supply, and even the destruction in osteomyelitis is due to compromised blood supply. Maxilla has got a very good blood supply. Okay, so it's exclusively in mandible, and yes, unlike your the focal sclerosing, which was purely on the molar, it can even extend into bicuspid region, or that means the premolar region. Okay, and yes, children and young adults is the same thing. Okay, young. So diffuse is in chronic diffuse sclerosing is in older adults. The other two was in younger adults. Okay. Now, if you go further, okay, I'll teach you some clinical features. Okay. Now, not very important, but just for the differentiation sake, I'm going to give you that acute and chronic. How do they, or I would say, yeah, how do they differ? So acute, you know, it's pus formation. So there will be pain, there will be trismus when the pus goes into your muscular regions. There's going to be paresthesia if the pus goes to your nerve region. There is going to be definitely, it's an infection, elevated temperature, lymphadenopathy will be there. Okay, all infection signs. Now loose teeth. Now it's basically periapical pus formation if it is there. I'm talking about acute and not condensing osteitis or chronic type. Okay, loose teeth will be there, difficulty in eating will be there, pus, definitely pus will be exudating. I'll show you the picture out there. Now, if you come to the chronic type, you say, I told you there's sclerosing type and periosteitis type. This is Garres osteomyelitis. Sclerosing type, usually it is asymptomatic unless there is a pain related to carious teeth or periodontitis. Carious is focal, periodontitis is diffuse. Now, Garres osteomyelitis. Now, this is very, very beautiful. You get bony hard swelling. In acute, if it's infection, the swelling is not going to be bony hard. In condensing osteitis, in diffuse sclerosing, there is no swelling. But Garres is very typical that young individual, very important, there will be a bony hard swelling. Okay, so that's the diffuse sclerosing osteomyelitis. Okay, so I just want to add here periosteum. And one more point, that there is swelling, okay, swelling out there in Garres osteomyelitis. Now finally, the most important area of discussion is going to be radiographic appearance. Okay, now individually I'll discuss one by one. In acute, I told you already that very little radiographic findings are seen, but you have to know a few key points here. Little or no radiographic features are seen for at least 2 weeks. 1 to 2 weeks. Okay, 1 to 2 weeks, no radiographic in acute. But now there's a lot of questions now. Okay, that is now basically in the first 2 weeks there is no bone destruction. Okay, so they can ask you a question here directly. In acute osteomyelitis, in early phase of acute osteomyelitis, all are seen except. So basically no bone destruction is seen. Please note that. Now, what is actually seen? The trabeculae gets, now that's very important. After 1 to 2 weeks, the radiolucent lesion starts developing. I'll give you a question also what is being asked. So still there is no bone destruction as such, but a slight radiolucent lesion comes yes, that's the question. Okay, first radiographic sign of osteomyelitis. It's not even widening of PDL. Okay, please note here, this is the option. Okay, I want, if someone can just go through the option and blurring of trabecular, widening of PDL, loss of vascularity, subperiosteal bone formation. So basically what they said, radiolucent lesion appears, then widening of PDL. Okay, so what is basically the reason? I told you what is the reason for this radiolucent lesion. That will be the first radiographic sign. Hope you understood. So basically it's blurring of trabeculae, okay, which is producing. That's the answer. Now in different ways they can ask you. It's basically the cause of radiolucent lesion, fuzzy, indistinct trabeculae. The trabeculae becomes a kind of, this fuzzy appearance. Okay, so blurring or fuzzy trabeculae. Okay, in acute osteomyelitis, that's a radiographic sign. That's the first radiographic sign. Then comes the second, that is which can be widening of PDL. Okay, subperiosteal bone deposition. It's basically it's a Garres osteomyelitis, loss of vascularity, the much later stage. So that's the first radiographic sign. Along with that, you will see widening of PDL. So that's one question asked for you. Now, chronic suppurative. So in acute we said 1 to 2 weeks, no problem. Then radiolucent lesion appears because of the fuzziness of trabeculae, then widening of PDL happens. Okay. Now chronic, we can divide it into 2 stages. What happens in the early stage? What happens in the established or much later stage? Now this is MCQ. Mottled appearance. Okay, mottling. Basically what happens? Acute stage we have, then chronic stage is coming. Okay, so acute stage there is fuzziness of trabeculae. Then what happens? Bone destruction begins. The moment it goes into the chronic phase, the bone destruction begins. Okay, so what happens there? Yeah, bone destruction, but now the immunity is good enough to repair it. So destruction repair happens. So what is the outcome? Mottled appearance. So basically in the initial stage, in the early stage, there is destruction plus repair. You get a mottled appearance. So this is a picture of it. Okay, now if you see here, see this bone destruction is there. Okay, so this particular area, there is bone destruction. But bone repair also taking place. So that's not the complete moth eaten appearance. That's what the next. There's no complete destruction. The moment it becomes complete destruction, it's a kind of a moth eaten the bone. Okay, moth eaten. But here there is bone repair also, there is mottled appearance. Okay, please note, don't forget, we're going to see another which is cotton wool appearance in condensing osteitis. So this mottled, moth eaten, chronic, suppurative. Okay, so that is destruction plus repair. Whereas moth eaten appearance, okay, that's in the established stage where it's due to severe destruction. Okay, so please note early stage mottled, established stage moth eaten. So how to remember this? Remember you're going for a party. Okay, so initially you get the soft drinks and everything. Isn't it? Then only eating comes. So eating is second. This is where confusion happens to most of the students. Okay, moth eaten or mottled, which is first? Eating comes later only. Okay, initially we have that starters or soft drinks, everything. So basically soft drinks. Okay, starters again eating only. So soft drinks. So just remember it like, or you are going for a wedding party, wishing the bride. So eaten is only a later phase thing. Okay, established. Also note, yeah, 2 very, very, very important things come here. Sequestra and involucrum. So basically, what is sequestra? What is involucrum? Sequestra is a dead bone. Now basically what is happening in osteomyelitis? The vascular supply is affected. So what happens? Necrosis, general pathology. What happens due to necrosis? The bone dies. So the necrosed bone is called a sequestra. Okay, the necrosed bone is called a sequestra. So basically due to necrosis. Now this indicates an ongoing infection. If you just open your radiograph or you take a radiograph, you see this kind of a lesion. Kind of a dead bone. You see that, okay, it's a ongoing infection. You have to treat it aggressively. Okay, now it indicates ongoing infection. Whereas involucrum is basically a new bone, not a dead bone. So around the sequestrum you form a new bone. That's called involucrum. Okay, and it's around the sequestrum basically, and it indicates a healing process. Okay, if you have involucrum along with sequestrum, it shows healing process. Okay, so it's a very important key point there. So that was chronic suppurative, moth eaten and mottled first, mottled appearance and moth eaten appearance. Okay, Now you come to the discussion which we had in the previous day, chronic focal sclerosing and the chronic diffuse. So basically it's a radiopacity, well-defined radiopacity. I've discussed this in detail. Adjacent to the roots in the bone. Okay, it's the bone, the tooth itself is not affected by the sclerotic process. No, basically all the osteomyelitis is basically in the bone only, but the causative agent will be tooth. Okay, now why I'm saying this point is, hope those who have listened to the previous lecture know this. Basically other lesions, okay, cementoosseous dysplasia, cementifying fibroma, this, okay, or hypercementosis, or you are cementoblastoma, all these are directly associated with the teeth. Now this is in the bone. Okay, please watch that lecture if you have confusions. Now basically it's all about carious tooth, I told you already, and mandibular first molar, no doubt. So basically this again the same picture, sclerosis, okay, the sclerosis out there, focal sclerosis, and this is diffuse sclerosis. Okay, now chronic diffuse sclerosing, I told you already, patchy diffuse radiopaque area giving a cotton wool appearance, okay, diffuse area basically. Now proliferative periosteitis, how does that look like? Sclerosis, okay, or a mixed radiolucent radiopaque. Why? Because new bone formation, old like that kind of appearance, new bone along the periosteum. There will be new bone formation along the periosteum. Okay, I'll show you the picture out there. Yeah, this is a picture of your Garres osteomyelitis. Now if you see here, this is a normal area, if you just consider. Okay, that's a cortical bone. That's a periosteum where you have. So now if you come here, see this. Yeah, this is the periosteal reaction out there. Okay, the new bone formed in the periosteum, and this is what gave rise to the swelling I told you, bony heart swelling, and this is the new bone formation in the periosteum. Okay, so it's a very, very important feature, new bone formation along the periosteum, presenting as parallel layers. Okay, now I've drawn a little unparalleled. Anyway, make it parallel. Okay, as I told you, you have to be a radiologist to, have all those imaginations. Parallel layers of bone, onion skin appearance, onion skin, and so, and basically this leads to thickening of the cortex and thereby causing the swelling. Okay, carious tooth is there definitely, but now it's a new bone formation, periosteal new bone formation. So yes, finally coming to the treatment part. Suppurative, what do you do? What is the cause? You give antibiotic. Okay, treat the dental cause. Okay, start the antibiotics, and if you need, go for the incision and drainage. Okay, and remove the sequestra. Okay, if it is there. Basically simple. Now chronic focal and chronic diffuse. Now diffuse is very elaborative, you can't do surgical, but focal, if you want, you can go for surgical. Basically treat the foci. Again, it's a carious lesion, so do either root canal or extract the teeth. Sclerosis, basically you don't need to do anything. Okay, no need of surgical intervention, but if in case you need it, you can go for it. Diffuse is very diffuse. Okay, so you can't go for surgical. Just treat the foci. If there is periodontitis or if there is anything, treat that. Okay, give antibiotics, and please note, too extensive to remove surgically. So that's one point to note. Okay, so I'll just write it down here, like surgical is a, I'll use another color. Okay, surgical is a question mark. Okay, so surgical is a question mark. That's a key point there. Okay, so now what about proliferative periosteitis? Again, treat the foci. Extraction endodontics. Basically, again, proliferative as well as focal sclerosing. Both has got the same etiology, which is caries. Okay, so finally, points to note. Osteomyelitis of TMJ can be treated by, I think this is a question asked for you, and basically initially you go for incision and drainage. Okay, then what? If it doesn't cure that, that's the question, you need condylectomy. You can go for condylectomy. Okay, that was a question and answer there. Okay, and one more thing, what about the tooth? Is the tooth vital or non-vital? Definitely, if the tooth is involved, it's due to caries spreading periapically. So please note, unlike the cementoma, cementoblastoma we studied, the vitality is lost. It's non-vital. And finally, two very important points to note here. Potts puffy tumor, have you heard of it? It's an MCQ. It's osteomyelitis of the skull, okay, which shows subperiosteal swelling, below the periosteum swelling. Okay, understandably, it's into the medullary wood, subperiosteal swelling with edema of the scalp. Basically, Potts puffy tumor, the simple term is osteomyelitis of skull. Now, there is one more disease called Potts disease. So, it's not Potts puffy tumor, it's Potts disease, which is tuberculosis of the spine. If your vertebral column, if your spinal cord, if your spine, the vertebrae gets infected by tuberculosis, it's called Potts disease. Whereas, so one is osteomyelitis, other is tuberculosis. Please understand the difference. Okay, so that will be the end. So now the time to review. Okay, the most important thing we saw was it is Staphylococcus aureus. Okay, then we saw the sclerotic is basically proliferation. The other was the destructive. Okay, pus formation, which was the suppurative was. Okay, then that is we have got focal and diffuse. Focal is very important point as younger individuals, other is in older individuals. Plus focal is due to carious lesion, diffuse is due to periodontal lesion. The radiographically you see in case of your diffuse you see cotton wool appearance. Okay, and yes, in case of focal you see that sclerosis, very important. And surgical is a question mark, I told you already, in case of diffuse because it's too diffuse. Then we came to Garres, where there is new bone formation in relation to periosteum plus bony heart swelling, and also all this reaction overall gives us onion skin appearance. Okay, now radiographic acute, what we saw, it's just a blurring of trabecular and then widening of PDL. Chronic, you have got mottled appearance to start with, then you have got moth eaten. So as I told you, this is a summary of the whole lesion. Okay. Now, if you have understood this much, this is the key points, then yes, it will be sufficient, okay, to watch. Or if you know this much, what I've said just now, it's enough, okay, for the crash course students, or I would say the students who are, writing the exam and they have a lot of portions pending and all those. You just need to do this, okay. Those much is sufficient. So thank you so much. Have a great day. In the next class, we'll discuss a little bit on the fibromas, which is again related to these. Okay, cementifying fibroma, cemento-ossifying fibroma, peripheral cementifying fibroma, central cementifying fibroma. All those things we'll be discussing, which is again comes under the differential diagnosis of this particular lesion. Okay. Now those who are watching on YouTube, is this called systematic learning? You'll ask me. Because in all our ads, you talk about systematic learning. Now basically, this is something which is comes under clinical discussion. Okay, what happens is that in our comprehensive course, we have got something known as basic lectures, and that is a major area of systematic learning where we go chapter wise, because osteomyelitis comes under what? Osteomyelitis comes under spread of infections. Your cementoblastoma comes under what? Tumor. Your cementoma comes under what? Fibrosis lesions, isn't it? And now your cementifying fibroma, all these are again connective tissue tumors. So actually this particular is a kind of a clinical discussion, an advanced level discussion. Okay, whereas in our basic lectures, everything we go in a very systematic, very chapter wise model. So my advice to those students who are preparing for next year, your first target is what? Clear your basics and concepts. So those who have already joined, they know it. We are doing subject by subject. Okay, we have started with the first subject, microbiology, then we went on to anatomy, then we went on to all those subject by subject, topic by topic. Now, in this particular round, my advice to you is forget about all these. If you want to watch this lecture, fine, on YouTube, you're watching it, very good, but focus on the app. What is there on the app? Now we are doing, for example, general pathology. Okay, so the first topic we did was what? We started with cell injury. We understood apoptosis, we understood necrosis, different types of necrosis. Then we went on to, now this will be nostalgic for the pre-senior batch students. You all did this last year. Anyway, then we started with the next chapter, which is the about inflammation. So like that, chapter by chapter, chapter by chapter. Then once your basic and your foundation is good, that is a stage we go on to the clinical discussions, differential diagnosis, okay, then quick reviews, all those things are the next stage thing. Okay, so yes, and that's also very, very important. Your basics are cleared, your basics are done, you have done your basics properly, then you're advancing. It's amazing. Now, I just want to add here one thing. Many students, they start their preparation without any guidance. Most of the time what they do, they do everything on one go. They don't wait for the concepts to be clear. Okay, for example, they start with, I don't know if some coaching centers also doing this, but this is not the way. Okay, your first round has to be your foundation. Okay, especially at this stage. At a later phase, if a student coming, then it has to be in a different method. Like for example, someone joining after Feb or after May or like that. But now it's all about foundation. Your foundation has to be very, very strong. Okay, so the students, the mistake they make is they start, okay, with, for example, the same thing I'll tell you, they start with microbiology. They do certain questions and they do some homeworks, they read some textbooks. Okay, there is no guidance. The moment they see a clinical question, they dwell deeper. Okay, students say that, okay, I'll read in detail. Okay, and then more detail. So usually how much time in the first round, how much time for a subject? 2 weeks. So 2 weeks over, 3 weeks over, 4 weeks over. What is the impression created to the student? We all have faced this, trust me. What is the impression being created? Oh my God, entrance preparation is something which is not under my control. One subject I'm taking 4 weeks, that means 20 subjects, how many? So this is where the problem comes. You have to do it in different rounds, even if you're joining in a later phase. Build your foundation, in between keep on revising them. What happens now? We have our senior batch students, okay, those are listening, that is your new batches. You know how they're doing, they're also listening to this, I'm sure. They're doing one subject in a week. Okay, and probably 1 to 2 chapters in a day. Because to reach there, you can do it overnight. It doesn't happen overnight. Your foundation has to be strong. Once your foundation has to be strong, you can go at a much faster speed. Much faster speed. Okay, so it's very important that at this stage, new batch students, please understand that it's all about building your foundations. You're watching it on YouTube, no problem, but follow in a very systematic way. Okay, continue in a very systematic way, though YouTube is going in a different direction. Majorly it's focusing on the crash course students. For the new students, you have a very systematically arranged lectures on your app. Go through that one by one. Okay, put your efforts, build the habit of learning. Slowly by slowly, we will be advancing. Do some questions, practice some questions, do some exams, which is there on the app. All those, then we will shift the gear next. Okay, so yes, I'll end my lecture there. So thank you so much. Have a great day and take care.